Thank you for joining us today for one of our Creating a Better Future webinar series. Today we will be discussing the madness behind the numbers. Accurate diagnosis, is it possible? I am Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Edmond Chan. Many of you are aware that our organization, we're a national not-for-profit charity and Canada's leading patient organization committed to educating, supporting, and advocating for the more than 2 million Canadians living with food allergy. However, you may not be aware that we're completely reliant on the generosity of donors to fund our work. So if you're able to consider a charitable donation to our organization, it would be greatly appreciated. This session will start with a presentation from Dr. Chan, and then there will be some time at the end to answer questions. I'd like to thank everyone for submitting their questions in advance of the webinar. We have attempted to incorporate a number of those questions into the presentation so that your questions will get answered in that way. And then if there is questions that haven't been answered, you have the opportunity through the chat box to submit those during the webinar. Before we get started, a couple of housekeeping items. The session is going to be for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. As mentioned earlier, if you have some questions that come up throughout the session, please submit them in the chat and question box. We'll try to do our best to get to as many of those questions as we can. And the last thing is that this webinar will be recorded and shared on foodallergycanada.ca afterwards in case you want to refer back to it or share it with others. Before I introduce Dr. Chan, I'd like to get a sense for the audience's familiarity with the various different type of diagnostic tools that exist today. So if we can put up a poll question, and for those who are managing a food allergy themselves or for a family member, if you could please indicate which of these tests you have undertaken. We'll just wait a couple of seconds for the results of this poll. All right, so there's the profile of those who are managing food allergy today as to which tests they've had some exposure to. That's very helpful for Dr. Chan. So now I would like to introduce Dr. Chan. Dr. Edmond Chan is a Canadian Paediatric allergist, a UBC Clinical Associate Professor and Head of the Division of Allergy and Immunology in the Department of Pediatrics at BC Children's Hospital, and a co-author of the Canadian Paediatric Society Practice Point on the introduction of allergenic foods. He is on the board of directors of the Canadian Society of Allergy Clinical Immunology and on the executive of the Allergy Section of the Canadian Paediatric Society. He is also a member of the Healthcare Advisory Board for Food Allergy Canada and steering team committee for the National Food Allergy Action Plan. I'd now like to turn it over to Dr. Edmond Chan.
Okay, good morning, everyone. Thank you very much, Jennifer, for the introduction. So I'm going to talk about accurate diagnosis and whether it's possible this morning. I'd like to, it's morning my time in Vancouver. And, you know, I'd like to just start by providing here my disclosures. The most relevant is the being a consultant recently for allergenists and also starting to do some research work with them. I'll get back to towards the end of the presentation what technology they're involved in, but it's the Epitope mapping. The objectives for this session are firstly to appreciate that with routinely available current tests, skin tests and specific IgE blood tests, that the accuracy of food allergy diagnosis is highly dependent on a detailed patient history. So many of you will already know that, but we're going to do a bit of a deep dive into why that is. And then secondly, to look at oral food challenges. Those are currently still the most accurate test, but examine the many barriers which limit access to it. And then lastly, to provide an overview of next generation allergy tests. So in preparing for this talk, it was a little bit challenging knowing that we have quite a varied audience ranging from parents, patients, to different types of healthcare professionals, to educators. And so what I've tried to do is to not have the lecture so complicated that it'll be too difficult for some members of the audience to follow, but also not have it too simple so that those who want a certain level of detail hopefully will come away feeling that they're able to get that. So trying to sort of have a little bit for everyone. So I'm going to start with just bringing everyone to the common point of deciding on what kind of food allergy we're talking about for this lecture. And it really is on the left, the IgE-mediated food allergy. So that's the immediate type of food allergy, typical onset of symptoms within a couple of hours of exposure to the food, with very typical allergens like milk, egg, peanut, tree nut. And it can be potentially anaphylactic, so you can have difficulty breathing or hypotension, for example. And so all the testing that we're going to talk about today will focus on testing for that type of food allergy. It will not, today, the lecture will not deal with non-IgE mediated food allergies, such as FPIES or food protein-induced enterocolitis syndrome, which is the delayed type of food allergy. For the FPIES, typically it's gastrointestinal symptoms exclusively. So focusing on the IgE-mediated food allergy, what essentially happens during an IgE-mediated reaction? And so this slide is courtesy of Dr. Cecilia Barron at Mount Sinai in New York, who gave a webinar that many of you may have heard recently. And what this slide is showing is that in those who are sensitized, so those who are at risk of these allergic reactions, they have production of allergen-specific IgE antibodies that are sitting on their effector cells, in this case the mast cell, and the same applies for basophils, which we'll get back to at the end of the talk. And those antibodies are just waiting for the individual to be exposed to what they're sensitized to. So in this case, let's say the patient's allergic to peanut. If they're exposed to peanut, if they ingest some peanut, then that contacts the antibody sitting on these mast cells, and that interaction there triggers off cross-linkage, a process which results in signaling through to the middle, quote unquote, of the cell, and it activates the cell to degranulate, so to release all these preformed mediators. And those mediators have all sorts of effects on your whole body, such as vasodilation, dilating your blood vessels, constricting your airways, resulting in skin reactions like hives and swelling, resulting in your gastrointestinal tract having symptoms like vomiting or diarrhea. And so that's what we see manifest, and this is how those cells make that happen. Now, in terms of diagnosing who has a food allergy, so who has already made allergen-specific IgE antibodies that will trigger a clinical reaction, we have these tools, many of them age-old tools. So history, skin prick tests, and specific IgE blood tests have been available for many, many years. Component resolved diagnostics, there's variable availability in different provinces, but it's been available for at least a decade. Oral food challenges have actually been available since the 1980s, but it's just that the availability is very sort of regional and very dependent on where you live and who's practicing in your area. And generally speaking, I'll get back to this, there's limited availability. And the next generation tests are not currently available in a toolbox yet, but the hope is that they will be. So to focus on the skin tests and specific IgE blood tests, are they accurate? That's always the big question for me and others. And really, it's qualified by it depends on the patient history. So we'll really, again, do a deep dive in this. And perhaps the best way to do this deep dive is to look at when things go a bit awry. So here's a case which I've entitled False Positives. And so this was an infant who actually lives in Calgary, who back when we were releasing the NIH American NIAID guidelines on early introduction, the mother had heard about the guidelines on television. And shortly after that, the child was 6 months of age, introduced to peanut butter at home. This infant had no history of eczema formally, but had dry skin. On the 5th day of giving the peanut butter, so the first 4 days was tolerated, on the 5th day, there was some redness on the face noticed by a mother, and she was a bit concerned, so then saw her family physician, who ordered the blood test, specific IgE peanut, and that returned at a positive number, 2 Ku per liter. And so based on that, the family physician wasn't sure what to do, so referred to an internist. I'm still not quite sure why an infant would be referred to an adult internist, but that happened. And so then mother showed me the piece of paper that the results were jotted on, and it's still to this day unclear to me what the numbers beside the foods represented, or why there were so many foods tested when the history was peanut butter, because mother told me she did not request more than peanut testing. But the piece of paper said peanut 4, almond 3, cashew 3, sesame 3, macadamia nut 4, and egg white 4. And I was a bit lost as to whether that represented millimeter diameter or the older convention of 1 plus 2 plus 3 plus 4 plus. And so, you know, they actually flew all the way to Vancouver to see me. And the story behind that was mother grew up in Vancouver and was neighbors with one of my colleagues at Children's Hospital, BC Children's Hospital. And she telephoned him, and then he recommended she actually fly over here to see me. And so was able to be triaged to be seen soon, because we tend to triage the young infants because this is such a pivotal time that we want to take advantage of for prevention. Otherwise, we lose the opportunity when they're 1 year and older. Then saw at 8 months. The first thing I did was, in addition to taking history, just basically, like, I'm not sure I trust these results, so I repeated those skin tests, and they were completely flat, completely negative. Then what I like to do is, when there's any hesitation, like to do the challenge or the observed ingestion. Observed ingestion means that, you know, it's a low risk situation, but I like to do that on the very same day that they come in for the consult. And so we did that immediately, and a child passed, and it allowed us to give immediate advice. And my diagnosis was simply contact irritation around the mouth. Before we gave the peanut butter, applied a layer of petroleum jelly around the mouth, and that took care of that. And so just to reiterate, the title of this slide was false positives. What false positive means from a general layperson perspective is that the patient has a positive test result, but actually is not allergic. And so some allergists debate that false positive is a bit of misnomer because they're making the antibody. It's just not clinically relevant. So you could say clinically irrelevant sensitization, but that's a mouthful. And so false positive is probably an easier way to convey that. And so, you know, why is the history so important then, given that case? Well, the history is very important because of this relatively high potential for these skin tests to give like 4 and 3 and 4 and 3 and all that. Like, you know, there's just a lot of children, especially, who won't give a negative result, partly because they have sensitive skin, partly because there's all sorts of cross reactivities that we'll get into in a moment. But the very complete history really helps reduce the number of false positives, because then you can minimize the number of tests that you do in the selection. And you can really, what I really over the years have really enjoyed about taking a complete history is you can really refine the result in terms of the interpretation. So if I get a 3 or a 4 result, whatever units that is, if I can say the child has never had a reaction to that food, I'm more apt to say to the parent, hey, this is probably a false positive, like, you know, and we should be doing more investigations and putting more thought instead of just immediately prescribing an EpiPen. Very important clues on the history are onset of symptoms. So typically within a couple of hours for IgE mediated, duration of symptoms less than 24 hours typically. The type of symptoms, typically the skin, urticaria, hives, swelling, and the respiratory system, cardiovascular with decreased blood pressure, and also gastrointestinal with vomiting, diarrhea. The type of food, like I mentioned earlier, it's really the common food allergens. You can expand what I mentioned earlier to seafoods, to sesame, to soy and wheat, but these ones that you expand to aren't as common as the ones that I put on the previous slide. And then, you know, really a pearl for me is whether the food is eaten regularly or currently being avoided. Because if it's been eaten regularly, that should actually be a sign that child's not allergic to the food, unless they're having these immediate symptoms every day. Now, skin prick tests, so they're confusing, basically. You know, not everyone uses the units of millimeters. Everyone should be using millimeters, but not everyone is. And for millimeters, a positive, it's pretty standard that a positive is 3 millimeters and a negative is 2 millimeters or less. And this is in relation to the saline saltwater control. So it would be if you have a bump with the salt water, then it's 3 millimeters larger than the salt water. Skin prick tests are ideally done by allergists, as their interpretation can be difficult. That's a general sort of type of feeling that we have. We've seen many scenarios of where non-allergists are doing these, and the interpretation is very difficult because of differences in technique. Even amongst allergists, there can be differences in interpretation, which makes it confusing. Generally speaking, negative results are more accurate. There's certain exceptions to that, such as seafood, certain tree nuts, fruits. Those can give false negatives. But the false positive rate is quite high, which is why they're not positive results as useful without a good history. And so we still tend to turn to the skin test as the first test after the history, because the results are available within about 15 minutes, and you can give immediate advice. But very important to stress that panel testing, kind of like that case, where you just test a list of foods, no matter what patient you're seeing, without regard to the history, that's inaccurate and simply problematic. Now, specific IgE blood tests, the next tool in the toolbox, they have a wider range of positives in the sense that you have all these numbers up to 100 kilunits per liter. Like, it's like rare, you know, it's really unheard of to have a skin test that's 100 millimeters. So with the blood test, you'll have it go all the way up to over 100 actually. The labs, typically the clinical labs only measure up to 100, but the research labs can measure over 100. And so lots of different numbers in between, not good reference ranges in the report that comes back. The allergists typically, in the sequence of the toolbox, order the specific IgE when the skin tests and the history are still inconclusive, or you know, a bit more useful too when we're seeing if a child's outgrowing the food allergy. Because of all these different numbers you get back, it's a bit more useful than seeing the same skin test over and over again, because you know, it's quite clear from research studies that even after a child has outgrown their food allergy, that the skin test stays positive for quite some time beyond that. Non-allergists in British Columbia can order a maximum of about 5 skin-specific IgE blood tests, but in other provinces, there could be the ability to order more than that. I just want to make a note here that in British Columbia, food mixes are still on the requisitions, and that we've tried to remove from the requisition, but it's something the labs haven't removed yet, and it's very confusing when those results come back positive, as they often do at low levels, because then you have no idea which of the 6 or 8 foods the child may be allergic to. Now, just to illustrate the complexity of specific IgE blood tests, I always like to show this to many people, that there's different quote-unquote cutoff points for different foods. And a common cutoff point that we think about is the 95% positive predictive level, PPV. And you can see here that not only between different foods is there a different level in terms of Ku per liter, but even different ages. So in the case of egg, if you're a very young child, a level of 2 is a pretty high chance of reaction. But if you're older, it takes a level of 7 for that same risk. And if you plot it out here in the case of peanut, you can see that 14 plots out to about 95% probability of reacting. And as your number here on the x-axis goes down, then your probability goes down. Most allergists who have a lot of experience doing food challenges would feel comfortable offering a food challenge when the probability of reacting is roughly 50% or so, which works out to roughly 2 Ku per liter. Now, just a little bit further tidbits on interpretation. The 95% PPV is not conclusive, although it looks conclusive on the previous slide. It still depends on the history. So just to hit this point home again, you could have one patient who has a blood test of 14, but eats peanut butter daily. And the reason it's 14 is because also allergic to pollen. You could have another patient with a level of only 1, not allergic to pollen, but during oral food challenge has anaphylaxis. So this, just illustrates that 14 is not necessarily the be all and end all. And it's also, this is a very common misconception, that blood test levels are not a reliable indicator of severity. So I've had, many patients with low numbers who've had severe anaphylaxis, go to the emergency room, need a couple EpiPens, and I've had, many patients where either by history or even we've done a food challenge, let's say for a research clinical trial, especially when you're doing with numbers that high, just get a couple of hives. And so what is the utility of these tests so far, the skin test and the blood test, when you have all these exceptions? Well, the tests are useful when the results align with history. So I don't want to say that they never align, because you do have patients where you have a recent convincing history together with a positive test. So bang, it's done its job. It's perfect. And you also have a history patients where you have an unconvincing history, such as they've never eaten the food before, and you have negative testing. And so yes, that's very reassuring. But when you have the flip side, the corollary of those, then clearly we need more tools in the toolbox. So such as recent convincing history and negative testing. Well, I wouldn't just say go home to eat. And then unconvincing history or no history of ingestion and positive testing. That's where we really need to be detectives and do more detective work. Now, could component testing, a fancier blood test, result in greater accuracy? So this picture is trying to show that there's actually shared protein sequences, peptides, between different plants. And so peanut is a plant, and apple is a plant, and pollen is a plant. They're all plants. And it turns out they all have certain peptides that they share in common, which are here shown in blue. But they also have different peptides that are unique, such as brown, green, and red. And so when you do a peanut skin test or regular peanut blood test in a patient with pollen allergy, it will actually light up because of the blue components that are shared between the two. So what we really need for greater accuracy is a peanut blood test that's green. And that's what a component test is. It's the quote unquote green peanut blood test. And so the one that's been used most commonly in research and clinical practice, that's the most diagnostic of true peanut allergy, so sort of the green blood test, is the ERA-H2 blood test that many of you may have heard about. And to this day, our study in BC that we published 5 years ago is still the only one that I'm aware of which correlated levels in Canadian children with what happened at oral food challenge. So what we did was we took a bunch of kids in our clinic, did ERA-H2, and then we did food challenge. And we found a 95% PPV. So that's cutoff that I talked about in the previous slides, where you would expect 95% to react of ERA-H2 between 2 to 3 in Canadian children. So what effectively that study showed was that with the regular blue peanut blood test, you have to have a number as high as 14 to be convinced. But with a new ERA-H2 green blood test, you only need a number of between 2 to 3. Now, why is this not the gold holy grail answer to our dilemma of how to get accurate diagnosis? It's because it's still a PPV, and you still have that curve that where you plot and the probability of reaction reaches 50%, 25%, and that sort of thing. It's not an absolute black or white. This is where there's really a big limitation still in these component tests, that these PPV levels have not been carefully worked out for all allergens. In Canada, really, we can say it's only been worked out carefully for peanut RH2. And also the cost is still a fair bit higher than the regular blood tests. And certain provinces, there's limited availability of allergens, such as BC. But just to drive the point home of it's not black and white, we had this 9-year-old boy in the study who had a long time ago a remote history of peanut reactions, so we thought maybe outgrowing, and then has had an allergic allergy to, I'm just going to click on here. Also is sensitized to tree and grass pollen. His peanut-specific IgE was low, 1.3. So you'd think, oh, maybe he's outgrowing. RH2 was also low, at least below this 2 to 3. So you thought maybe outgrowing. RH8 was confusing. Basically, all three numbers are similar. And then lo and behold, we do the food challenge and child has anaphylaxis. So this is where the numbers were low, and none of them were 95% PPV. You had your pollen component being confusing, and it's really still relying on the food challenge. So hopefully this illustrates to you why it's not enough. There's one sort of algorithm here from one of the recent papers, which shows that you could put all this together that I've done so far. A good history, looking to see whether a child's outgrowing, do the skin test or blood test, and these are the numbers that we're looking at. A number over 8, I would add, or a number over 15 for the blood test, are where we're above these 95% PPVs and the peanut allergy is likely, where you probably don't need to do a food challenge. And then it's that gray zone in between. This 3 to 8 stymies us so much. This 0.35 to 15 stymies us a lot. And even the RH2, you just pick your cutoff. Is it 1 or 2 or 3? That stymies us. And so that's where it's leading us to a food challenge. Now, I just have to add that in the US, so this was Australian American authors, they recommended a hospital-based challenge, but in Canada, as most of you know, the majority of allergists practice outside of hospitals. Now, a very real-world dilemma is that the situation is very tricky for patients who are already avoiding a number of foods before seeing the allergist. So if they've been told by a friend to avoid foods or given positive results by someone, this is what the textbook or the research paper does not adequately address. And it's a very real-world issue that I've really had to hone my craft in, even since I've been practicing, and really discuss with families which is the lesser of two evils here. Is it the risk of a false positive like I just described if we go ahead and test, or is it the risk of continued avoidance, possible malnutrition, and misdiagnosis? And so my approach, which I feel nicely balances the literature and patient expectations, is I discuss all of these risks with the family, allow them to have input in the era of shared decision making, even before that catchphrase. And if I was to proceed with testing, I test as few foods as possible. I actually tell them that. I don't do panel testing. And if that was your expectation, you're not going to get it here. But I will test to the foods that matter the most and interpret them very, very carefully with you. And I will celebrate negative tests with you. And I will promise that if any tests are positive, I'm not going to immediately prescribe an EpiPen. If the tests are weakly positive, kind of like that algorithm, then we probably, at the lower end, actually could even say maybe you just try the food again. If it's sort of, getting nearer to the higher end, I'm at the stage of my career where I have this lower end, higher end, even within the 3 to 8, then I certainly go to the next tool in the toolbox, which is a food challenge. Now, just to mention, some of you may have heard of this tool that CSACI and Food Allergy Canada both kindly supported, that we developed at UBC, allergycheck.ca. You can all just take a peek as we're going along, because it's a mobile website. You don't need to download an app. what it does is it walks primarily patients and parents, but also primary care physicians may find it useful. It walks individuals through symptoms that they've noticed, and it divides it up into systems. There's even an area for lab test results, the type of test that we just discussed. And as you click through what you've experienced with your own child or with a patient, it sort of gives you a hint as to whether it's a higher risk for food allergy or a lower risk, and what to do next, whether you seek professional opinion, whether you can retry, and things like that. And it's a really sort of novel electronic way to get around some of these pitfalls in the tools in our toolbox. But it's not, again, just like the disclaimer, it's not meant to completely replace a professional opinion. Now, moving on next to the big area of oral food challenges. So, the caveat here is it's very accurate, but there's many barriers which limit access to it. And so what is a food challenge? When is it done? It's done if there's no recent convincing history. It's best to get patients to understand the importance of eating regularly after they pass the food challenge, or else there's a risk of redevelopment of the food allergy. This is something that has been published more and more the past few years. What's the point of doing a whole bunch of food challenges and spending valuable resources on that when the patient's just gonna go home and sort of quote unquote never eat again and risk redevelopment? Better to allocate those resources to a family who's motivated to eat it regularly. It's done for delabeling scenarios, ruling out a food allergy when other tests are inconclusive, follow up to see if a child's outgrowing, and also, of course, patients who've been told they're allergic by others. And I already mentioned how it's best offered when there's about 50% chance of tolerating, which equates often to a blood test level of 2. Different allergists, you'd be surprised to find different allergists have different comfort levels with this 50%. Some aren't comfortable and they have to, feel they have to wait until there's like an 80 or 90% chance of tolerating. And some families as well, they feel compelled to wait until that percentage before they do it. There's quite a role for food challenges in prevention and treatment. So this has connections to the talk that Dr. Abrams gave and the talk that Dr. Upton will give, in that you can't adequately do prevention and treatment properly unless you offer food challenges to those patients at certain points of the journey. And so hesitant families for introduction at home for young infants, or OIT, oral immunotherapy. Some patients will need a baseline food challenge, and certainly during the course of OIT, OFCs are needed to assess effectiveness. Now, some of you who've experienced OFCs, as per the poll, will have experienced this, but typically you have to sign consent, you understand the risk of anaphylaxis. There really should be a trained, experienced, certified physician supervising. And if there's no reaction, typically it takes about 3 hours, and it can take quite a while, 4 to 8 hours, to manage a reaction. We try to aim for about between 4 to 8 grams of protein, and typically the amounts are split into graded increasing amounts every 15 to 20 minutes. There are certain special situations which warrant further discussion before proceeding, such as how to deal with subjective symptoms, making sure asthma is well controlled before doing the food challenge, dealing with children who have a strong food aversion, and doing infant OFCs, because it's quite new, the concept of doing infant OFCs, and not all practitioners have a comfort level with that. Now, just published very recently, we did a study using mixed methods to look at, in Canada, the first ever study that was done in Canada on this, what are still the barriers for OFC implementation. And so this was surveys of allergists, pediatricians, and parents, and we did some focus groups with parents. And we found barriers that were somewhat surprising in a way, but somewhat expected. Many allergists cited lack of resources. A chunk of pediatricians only refer to allergists who do not do OFCs because they have the shortest wait times. That wasn't a great outcome to discover. And 50 to 70% of parents worried about severe reactions requiring epi, and that's why it was a bit of a barrier for them for doing the OFCs. And some solutions were that allergists wanted guidelines for which OFCs to do in hospital versus in the community. That comes up from time to time. 98% of pediatricians, would refer to allergists who have training and expertise. And so this, stresses how we should increase the training expertise, sometimes easier said than done. And then over 80% of parents desired hospital OFCs. Again, that's not a reality in Canada, or at least more education and psychosocial support. And so when you look at data like this, so latest prevalence data published a couple months ago by Ann Clark and colleagues, we're still looking at about 9% of the population, a lot of Canadians having food allergy, over 3 million, and we're still looking at allergist workforce of 27 in BC, 84 in Ontario, 56 in Quebec, hardly any in Atlantic Canada, like roughly 200 allergists across the country. So 0 point something for the ratio, which should really be much higher than that. How are we ever going to be able to do enough food challenges, not to mention OIT, for this many patients? And so really, too many barriers, and we need something else. And we need a promise. We need the promise of next generation allergy tests, which is really the bottom line, is how can we diagnose food allergy with fewer OFCs given all these barriers? And so I'm going to focus on two, which are the most promising. The first is the basophil activation test, the BAT test. What is it? It's measuring a patient's basophils and the response that those cells have to exposure to the food that the patient's allergic to. So basophils are a type of white blood cell and taken from blood and stimulated with the food of concern. The basophils will, in the test tube, then degranulate, and we're going to see cell surface receptors upregulated. The barriers to this test and the next one are largely the same with respect to we need standardized testing procedures in different labs instead of different labs doing different protocols. We need validation, which typically means we need it tightly correlated with the gold standard of the oral food challenge, kind of like how we did that study with Dr. Leo and colleagues in 2015 on the AirH2, where we measured AirH2 and we did a whole bunch of food challenges in the same patients. You need to do ad nauseum the same type of studies for different foods with the BAT test. And also cost effectiveness. I already mentioned cost as a prohibitive factor before, but if it costs hundreds of dollars for each food, healthcare systems are going to go broke and not accept this. The big limitation though with BAT testing is you need fresh blood. So the test has to be done within 4 hours of collection. You think of the way you go to your local lab and get the blood, and then the result comes back sometimes days or weeks later. How are we gonna get it done that efficiently? I'm just gonna show Dr. Barron's slide again. So here, just simply substitute basophil for mast cell. So let's say we're assessing peanut. Peanut latches on to those antibodies on the basophil, and you get degranulation. But you don't just get degranulation, you also get these cell surface markers, such as CD63, CD203 being expressed. And they go through a machine called a flow cytometer, and that just looks at light signals for these surface markers. And the brighter that they light up, the higher the blood test level. And that correlates with true clinical allergy, because essentially you're replicating the food challenge in a test tube. That's the best way to think about the BAT test. Now, the other cutting edge test is the Epitope map. What is that? That is where you look at a constellation of these specific IgE antibodies, not just, thinking about it simply, not just that one peanut specific IgE type of assay. you're looking at different regions of these food proteins in different patients and looking at a complex binding pattern, which is read by a fancy computer that is using machine learning to spit out a result which is very unique to that particular patient. It's so unique that it has been proposed to give accurate diagnosis in parallel to a food challenge, and not only that, help to predict which patients will actually outgrow, which will have more severe reactions, and which will respond to OIT. So again, achieving what the food challenge does in all of these ways. Similar barriers as what I just mentioned with standardization, validation, cost effectiveness, but this does appear to be a bit closer to use outside of research, primarily because from my point of view, you don't have that less than 4 hours fresh blood requirement. And this is a little picture which shows here. It's hard to show because it's quite complicated. Hard to show a simple picture to convey how it works. But here, let's say you have peanut protein and you have these different regions called epitopes that bind to antibodies. You have an orange and a green and a purple region. And so you have all those regions in the assay, the test, and then you bring in the patient's antibodies, these purple antibodies. And so different patients will latch on to different colors to varying degrees. And the green antibody is just latching on to the purple antibody, which is latched on to the epitope. And you get this, instead of just this one signal for something like AirH2, you get a variety of signals for different regions of the AirH2. And you get this very colorful, very unique profile. So to conclude then, to summarize, accurate diagnosis is possible, but with caveats. History is very important for interpreting our current tools. Food challenges are very accurate, but many problems with access. Bear in mind that to successfully do prevention and treatment, just to tie it in with the other webinars, you need to rely on OFC still, and that next generation tests provide hope for the future. Accuracy was less need for OFCs. I'd really like to acknowledge Food Allergy Canada for putting on this series of webinars to replace the conference that was supposed to be in person. I'd like to acknowledge all my research and advocacy collaborators. I'd like to put a shout out to my research manager, Leanne Solar, and one of my research coordinators who had spent a lot of time on that World Food Challenge study with me. And just to show this slide, that tomorrow you will be receiving an email inviting you to participate in the impact study. We're actually trying to develop the first ever in the world screening tool for food allergy specific anxiety. And I'd really appreciate if you helped out with this because it's such an important obstacle to doing things like food challenges. And so with that, I'd like to turn it back to Jennifer.
Great. Dr. Chan, we're going to take some questions now, and I would invite you to turn on your webcam so we can actually see you.
Okay.
Great. Okay, so we had a lot of questions come in, and I'm going to try and focus on the ones that were that came up most often, and that we want to start with the retesting and the delabeling topic. So the questions are centering on what's the best practice approach on retesting and the idea of delabeling. And I want to give you two scenarios. One is, an infant that was diagnosed at the age of 1 with an allergy, okay, or an adult who was previously panel testing and has avoided multiple foods. So talk to us about what would be the approach that people should take in those two scenarios.
Yeah, so with the first scenario, that infant who was diagnosed at 1, it really depends on how certain that initial diagnosis was. So if we, had an infant who was never exposed to the food and had a weekly positive test, that's in that sort of part of the algorithm that I showed before, which is like a real lower end of the gray area. And I might even, if I have that result and I can see it documented that it was like something like 3 millimeter, I might jump right straight to an observed ingestion slash food challenge. Um, but if it was at the higher end of that gray area, so closer to 8 millimeters, and especially if that infant had some type of history, so maybe immediately upon ingestion there were actually some hives somewhere on the skin, then I would have to repeat some of the tests. So probably go through the skin test and then the specific IG blood test, and then based on the updated result, make a decision as to whether or not to do a food challenge. For the adult who had panel testing, it probably is more likely that lower end of the gray area without, being given more history. Just, having seen some of those scenarios talked about, over and over again, those adults typically don't have, too much of a convincing history, and often they're not even that atopic to begin with. And so they may have presented to their physician with some indigestion or maybe some irritable bowel type of symptoms. And often for that, you can really just have that discussion of, do we really need to repeat any tests? Can we just look at these tests, and if they were on the low end of the gray, just reintroduce those foods into your diet. Of course, if they're on the higher end of the gray, it's similar approach. We might have to repeat tests and then strive to a food challenge. So it always just goes back to, the history and the magnitude of the positive within that gray zone.
Right. Now, so how accurate is a test if the allergen has never been eaten? I mean, that's one of the issues with the panel test, but that question has come up. How accurate is it?
It's really not. So almost all of the studies that you saw me present on these cutoff points, 8 millimeter skin test, high likelihood of reaction, or 15 kilonewtons per liter, for something like peanut, high likelihood of reaction. They're all based on studies where the patient has had some type of, usually remote history, or some type of history in the past of having hives or some kind of reaction. Those studies are not based on the infant or child who's never ever ingested the food before. And I'll tell you a scenario of where research even makes it kind of more confusing, because you look at the LEAP study, which Dr. Abrams probably discussed at the last webinar. So you'd think that's a golden opportunity to study this phenomenon of a very big skin test or high blood test and never eaten before, especially in an infant. Well, what did the LEAP study do? They actually excluded all infants with a skin test of 5 millimeters and above. So that possibly was like maybe the last opportunity we had to do a randomized controlled trial in hundreds of infants who had never eaten a food before, and yet we lost that opportunity. It's like the biggest weakness of that study. I love the LEAP study, but the biggest weakness of that study was they didn't do a food challenge in infants who had 5 millimeter skin test and above. So we'll never know. We're just left to guess that most of those infants would have probably been allergic or reacted, but we'll never truly know.
Right, right. Now, so what's your recommendation with people that are thinking maybe my child has outgrown? Like, should they be going to their allergist, and what tests should they be requesting, and how can they make the interpretation on outgrowing?
Yeah, so we just go back to the basic principles. Always go back to your toolbox and that order that the
Yeah.
tools were presented in, and the history I presented first. So even as a parent or a patient, you don't even have to, if you've had a previous assessment and it's really convincing assessment, you don't even have to necessarily get a reassessment if you had a recent convincing history. So let's say a couple months ago, you accidentally ate something with peanut in it, and you had quite a convincing reaction. You had some hives immediately, and you had some swelling. Of course, if you had quite severe anaphylaxis, that's reason in itself to get reassessment, just to discuss, how you can reduce the risk of that severe reaction in the future. But if you had a convincing reaction and it was like sort of mildly, moderately severe, and not terribly severe, you'd probably want to hold off on getting repeat skin tests or blood tests. If it's been many years, and this is where there's different varying levels of practice. So, if some allergists feel that it's been more than a year, maybe you should get retested. Some allergists feel if it's more than 5 years, you should get retested. I like
Right,
to I like to decide on that based on the natural history of the food, the specific food.
right,
So we know from a lot of data that milk and egg allergy are more commonly outgrown. So that's the type of food in a child I'd assess more frequently, like let's say every 1 or 2 years. But if it's peanut, especially if they're a bit older, if they're getting to school age, there's no way I'd want to retest peanut every year because the natural history of peanut tells us that less than 20% of children are going to outgrow their peanut allergy. So why would you want to test peanut every single year? You'd want to wait a bit longer, like
right.
maybe 3, 4, 5 years kind of thing.
Okay. Now, and there is a bunch of questions also around oral food challenges. Okay, and 35% of our audience indicated they've been through an oral food challenge, but there's a large portion that haven't. So when do you decide it's safe to do an oral food challenge? And tell us about what a successful challenge looks like, and then tell us a little bit about what a failed challenge looks like and what's the learning there.
Yeah. It's not the easiest question to answer because there's so much variability. Like the whole lecture of illustrated variability, because accurate diagnosis is such a sort of a difficult thing to get at. But on a very basic level, that 50% cutoff point for the blood test is kind of like an easy thing to think about. So a level of 2 Ku per liter. Of course, then there's a nuance of, that's best for milk, egg, peanut. And once you start venturing outside of those three foods, there's less data available. But just to, if you don't want to get too confused with what I'll say next, just think about 2 kilunits per liter and no recent convincing history. Now, what I'll say next is that there's a lot of dependencies on comfort level of both the patient and family as well as the allergist. So on both sides, there are many that are not that comfortable with 50%. 50% has various meanings too in itself. 50% means of any reaction, but it doesn't get at the risk of anaphylaxis. And so for that, you actually have to go through data which describes different allergist offices and their risk of anaphylaxis. And generally speaking, it's the allergists who offer food challenges where the skin test is a bit bigger or the blood test is a little bit higher than 2, which end up increasing their risk of anaphylaxis. So in our clinic, it's amongst the highest numbers that I'm aware of. We sometimes run up to 15% risk of anaphylaxis with the food challenge. But in a community office, it's probably like often less than 5%. We're in a hospital, right? So there's those subtle nuances there too
Right.
of risk of reaction versus risk of anaphylaxis. But it's really shared decision making, getting that consent signed, and we don't want to force anyone. Yeah, like our study showed, maybe families just need more education and need more psychosocial supports,
Right.
and they're just not ready yet. And I would say that that's something that you and I have talked about over the years. That now
Right.
that our OFC study on barriers has been published, maybe we can get a section of Food Allergy Canada resources just dedicated to more education about OFCs.
Right, right. You know what? Unfortunately, this is such a big topic, and I'd love that we would have another hour, but we don't. And so I'm going to close with this question. So let's go back to the session title. It was, this was about the madness behind the numbers, accurate diagnosis. Is it possible? So can you give us some final thoughts about this in terms of the answer to that question and what the future holds?
Yeah, I'd say that it's always been possible, at least since I've been a pediatric allergist and a trainee. So I'm going to date myself. I did my fellowship between 2002 to 2004, and it was very, very possible already then to do accurate diagnosis using a very tight history, careful history, careful selection interpretation of skin and specific IgG blood tests, and doing the oral food challenge when indicated. But the gap, the unmet gap, is that there's varying levels of access to that degree of rigor.
Right.
And so
Right.
I'd say we still have to improve that level of rigor. There's still, data suggests we're not near that. And there's lots of barriers. As if we can circumvent some of the barriers with the solutions that were found in that study I just showed, we'll be closer to accurate diagnosis. But at the end of the day, we can't rely on food challenges just based on the number of people at risk or who have food allergy and the small numbers of practitioners of certified allergists. So my greatest hope at this moment in time is, when will we get these next generation tests such as BAT or epitope mapping? I'm putting a lot of excitement into that next generation, how we can build that into our toolbox in a cost-effective fashion.
Great. Well, thank you very much, Dr. Chan, for both your time and expertise. I'd invite you to turn off your webcam at this point in time.
Thank you for everyone's participation. Thank you for Food Allergy Canada and everyone's time.
Terrific. Thank you. I just want to reference a couple of things before we close off the session, because I know there were many more questions that were submitted on topics that were outside of diagnosis. And so we want to make sure that you're aware of some of the other webinars that are coming up and that have happened under our Creating a Better Webinar, or Creating a Better Future webinar series. So a couple of notes. Dr. Julia Upton on June the 17th will be hosting a webinar around immunotherapy. On the 24th, we've got Dr. Moshe Ben-Shoshan talking about understanding when to use epinephrine. And for that one in particular, please submit your questions now, because that one is going to be a Q&A format. And the more questions that we have in advance will help us inform the content and get better to answering the questions that you may have. As a reminder, another point that I would like to make is we have some other webinar content that's outside of the Creating a Better Future series. We have recently done some content on introducing allergens to babies during COVID, and there's other webinars on early introduction guidance for the prevention of food allergy. And you will find that in the same place at foodallergycanada.ca/webinar. So head to those resources and have many more of your questions answered. As a reminder, you'll get a short survey through GoToWebinar immediately after this that will pop up on your screen. You will also receive the survey in an email in the next hour, and we'd ask that you take a few moments to complete it for us, because your feedback is crucial. It helps us improve our future webinars, understand what sort of questions are on your mind, and any additional comments that you might have. We would like to thank the sponsors for this webinar series: Allergect, that's now available in Canada, the Walter and Maria Schroeder Foundation, Sean Delaney Memorial Golf Classic, and EpiPen. In the next few days, you will be receiving a recording of this webinar. It will be available at, again, foodallergycanada.ca/webinars, and we would invite you to share that with others who you think may benefit. So thank you to everyone for joining us today, and to Dr. Chan for his insights and expertise. This now concludes the webinar.